of this schedule. Both the Food and Drug Administration, the FDA, and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, FDA believes that it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written or oral statement to advise the committee of any financial relationship that you may have with the sponsor, its product, and, if known, its direct competitors. For example, this financial information may include the sponsor's payment of your travel, lodging, or other expenses in connection with your attendance at the meeting. Likewise, FDA encourages you at the beginning of your statement to advise the committee if you do not have any such financial relationships. If you choose not to address this issue of financial relationships at the beginning of your statement, it will not preclude you from speaking. The FDA and this committee place great importance in the open public hearing process. The insights and comments provided can help the agency and this committee in their consideration of the issues before them. That said, in many instances and for many topics, there will be a variety of opinions. One of our goals today is for this open public hearing to be conducted in a fair and open way where every participant is listened to carefully and treated with dignity, courtesy, and respect. Therefore, please speak only when recognized by the chair. Thank you for your cooperation. Will speaker number one step up to the podium and introduce yourself. Please state your name and any organization you are representing for the record. Will speaker number two step up to the podium and introduce yourself. Again, please state your name and any organization you're representing for the record.
Yes, man. Can you raise this up? Can you hear me? Yeah, sorry. My name is David Shirley. I have never communicated with the Ameren Corporation. I am a shareholder. I'm not going to get rich off Ameren. But about a year and a half ago, I started studying some of the scientific research done in their product. And over the last year and a half, I feel very strongly that there's validation in it. May I start? Chairman, is it okay if I start? Okay.
Please.
Thank you. I had quite a few notes put together. I want to talk about some of the benefits of EPA and some of its anti-inflammatory abilities and markers, but I'm going to put that on hold. First time to ever come before this distinguished group. I really appreciate that. My comments may seem a little strange. I'm a veterinarian by profession. I'm going to leave all the statistical stuff to my daughter who's studying biostatistics at school right now. She's much smarter than me. As a veterinarian, I've been sitting here looking at a lot of the presentations. One of the things that's, I guess, is a little perplexing is that we're locking EPA in with a mixture of omega-3s and niacin and fibrates. And I know we're looking at lowering of triglycerides and the LDL-C markers. But it's a little perplexing. When I was working at one of the places, we had a couple of gals there that were incredible Schutzen trainers. For those who don't know what Schutzen training is, it trains dogs for extremely hard work. They were very talented. One of them was, I think she was the first female judge here in the U.S. But as I'm sitting here thinking, pondering, and I try to apply this to my life, I'm thinking, you know, this would be like me seeing their ability to train these dogs to go down to the dog pound and get the first 50 dogs and see their ability to show results with this dog that they have the ability to train these animals, and they would fail. They'd fail miserably. But if I went down to the shepherd rescue, then their abilities would show. And I think that's what's happening here with our EPA, as it's getting blocked in with all these other studies that, in my opinion, need to be thrown out. Even with the positive GSEP, I think that study should, I know we have to look at it, but it's not apples to apples. The only study I've seen is the JELIS study, and the EPA there was 1.8 compared to 4. But but it needs to be looked at on an apples-to-apples basis, and that's just, it's bugging me a little bit, honestly. Especially when we're in a subgroup, which once again, I know it's a hypothesis, but we're seeing a 53% improvement, and I know it's an open label. But as a veterinarian, if or as a person, if I'm coming in with left arm pain, and I'm on Vascepa, I'm not going to say, okay, I'm not going to go to the doctor. I'm going to go to the doctor regardless. There may have been some preliminary, putting together some of the preliminary studies that might show bias, but certainly not from the standpoint of the doctor or the patients, in my opinion. Another example, I get these old cats coming in that are low on their potassium chloride. They're chronic renal disease cats, and they'll go into acute renal failure at times. And the potassium's low. I have to spike the potassium into their fluid bags as we try to get them through this acute crisis, azotemia. In the process of doing that, I've come to learn that amount and concentration does matter. So when we're looking at these studies, the amount of EPA, the concentration amount, it does matter, at least in my opinion. And finally, on a little more personal note, my wife was diagnosed with diabetes a couple of years ago, and she's doing very well. It was a wake-up call for us. But unfortunately, she doesn't fall into this category. But as I'm thinking about what her options would be if she did fall into a mixed dyslipidemic category, honestly, I'd probably increase the statins that she was on. But I would have no reservation to put her on Vascepa with the safety profile that I'm seeing from them, as well as the benefits from my own personal study that I'm finding with EPA directly. So a couple of hours from now, everyone's going to be voting, and I admire you once again for your abilities and your knowledge. Please remember the Schutzen training. Please remember the potassium chloride, and please remember, if this is a family member, would you feel comfortable having them on Vascepa? I guess I just hope that the safe unrealization of this drug doesn't blind our ability to look forward to future studies. Thank you very much.
Thank you. Will speaker number 3 step up to the podium and introduce yourself? Again, as a reminder, please state your name and any organization you are representing for the record.
You know my slides, please? Thank you. My name is George Grunberger, and I'm Vice President of the American Association of Clinical Endocrinologists. I represent the organization here. ACE paid for my travel expenses, a sponsor did not. I'm also chairman of the FDA committee for ACE. For those of you who don't know, ACE is the world's largest organization of clinical endocrinologists, and you can see the mission statement in front of you. Earlier this year, in April, ACE issued its comprehensive diabetes management algorithm, which is published in Endocrine Practice, and you can look it up at website aac.com. And for the first time, we included such associated disease states as obesity, hypertension, dyslipidemia, because patients with diabetes don't just come to us with high sugars. If you look on the dyslipidemia side of the ACE algorithm, we felt, first of all, there's no such thing as a low-risk patient. So we looked at desirable levels, a variety of lipid parameters, which we would recommend for patients with moderate or high risk. And in addition to the LDL cholesterol, we also listed non-HDL triglycerides and ApoB and also LDL particles, just to get us on board with what we would like to see in our patients. And we recommended, after the blood is drawn, lipid levels are assessed, and the cardiovascular risk is calculated, that everybody gets put on a statin alongside with the therapeutic lifestyle changes, with few exceptions, obviously, people who have very high triglycerides or people who cannot tolerate statins. And then one would repeat the lipid panel to make sure that the levels are achieved. If the levels are not achieved, then try to intensify the therapy to achieve the desirable levels. And in some patients in whom maximum statin therapy and a maximum efforts at glycemic control and therapeutic lifestyle changes don't work, we do need to consider combination therapy. And some of these things are outlined to help our primary care physician colleagues to make those kinds of decisions. So what's the problem in managing dyslipidemia? Well, the problem is that we, as we heard this morning, really feel that statins are the only sort of proven therapies for coronary heart disease risk reduction, for our patients on statins, on medications. And so some people can present with very high triglyceride levels, and these obviously can lead to further risk of pancreatitis. We have to consider a combination therapy. And we know that fibrates can reduce triglycerides by 25 to 40%. But we also know that gemfibrozil, for example, raises the Cmax and the area under the curve for most statins by inhibiting statin clearance. And so that might result in some risks for our patients, whether it's myopathy, myositis, so increased risk of rhabdomyolysis. And fenofibrate can also have some adverse events in patients with diabetes. And so we, as we heard this morning, know that there is a category of medications out there, supplements, the polyunsaturated fatty acids, especially from fish oils, which can lower triglycerides and hopefully do not appear to interact with the statins as some of the other medications can. So it's possible that for those diabetic patients who do have combined hyperlipidemia, combination lipid-lowering therapies may be necessary if they don't achieve the desirable levels of statins alone. And so we would like to postulate a review regarding the safety of co-administration of statins and omega-3 fatty acids by FDA would be quite helpful to our professionals and patients. Now, as a policy, ACE does not advocate for approval of any specific drug. But given our mission statement, we know there is a great need for new drugs to help manage the ever-increasing burden of diabetes, obesity, and cardiovascular disease in our society. And we do need more effective and safe medications to improve the lipid control and cardiovascular risk for our patients while trying to minimize those undesirable side effects. Okay, with that, I thank you very much for your attention.
Thank you. Will speaker number 4 step up to the podium? Again, introduce yourself with your name and any organization that you are representing for the record.
Good afternoon. My name is David Sabgar. I am a cardiologist in Columbus, Ohio, with a focus on clinical care. I'm also the CEO of a nonprofit named Walk with a Doc. I'm in support of my travel here today, but I've not been compensated for my time. Here today because this is important to me. I've devoted my work life and a lot of my personal life to fighting sedentary lifestyles and in doing so improving health. I volunteer for this nonprofit that focuses on increasing activity of communities around the country. We have 114 sites in 29 states, and what we do is we try and pair physicians and patients in parks to get at this 97% sedentary lifestyle. We do this so we can pare down these lists of 15 to 20 medicines through exercise and appropriate diet. And sometimes, despite our best efforts, through diet and exercise, our patients still need medication. As a cardiologist, I, of course, look at lipid panels all day. Every day I see patients that are at significant risk taking supplements such as red yeast rice or fish oil. This does not help them. They need to be on something regulated, a regulated prescription that requires FDA oversight. Many patients and even physicians and healthcare providers are confused and think that supplements are a natural alternative to over-the-counter drugs or prescription meds when they're, of course, regulated differently. And as we know, there are no over-the-counter omega-3s, and often when the patients come in with triglycerides above 200, they need to be treated. And as you know, often patients with elevated triglycerides have high LDLs and have other metabolic conditions. The therapies they take must help their patient care and be safe and effective. We don't want the treatment to exacerbate another problem. So omega-3s in particular have created confusion to the consumer, and patients feel as if they can get it in a butter spread or something like that. They don't need to take it in the appropriate dose. Triglycerides are a risk factor, of course, for cardiovascular disease, and they need to be addressed. We fight every day to promote healthy lifestyles that may keep patients off certain medications and improve compliance in doing so. But there are many times that these medications are needed. And if they are needed, we want to make sure that they are doing it right. And that's all I have today. Thank you.
Thank you. Will speaker number 5 step up to the podium and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. My name is Ray Bassery. I'm an internist in private practice for 26 years in the Hudson Valley of New York and a clinical assistant professor of medicine at New York Medical College. Amarin supported my travels here today, but I have not been compensated for my time, and I am not a consultant to the company. I'm here to address the issue of optimizing patient management of very high triglycerides for two groups, women and diabetics, which are at particularly high risk for cardiovascular disease. My clinical experience includes treating patients who have been diagnosed with elevated triglycerides and also made a personal decision to self-medicate with dietary supplements. I would like to highlight the case of a Latina female in her mid-30s that I first treated 3 years ago. Anna had multiple cardiac risk factors, which included diabetes, elevated cholesterol, triglycerides greater than 500, smoking, and a family history of premature cardiovascular disease. We identified the risk factors and began treatment. Anna started prescription medication that significantly reduced the cholesterol and triglycerides. I prescribed a generic statin and branded prescription omega-3 medication. She also quit smoking and controlled her diabetes with diet and exercise. Approximately 1 year ago, Anna lost her health insurance and was lost to follow-up until she returned to the office over the summer. Anna reported that she had maintained her weight and with diet and exercise. Fortunately, her glucose was well controlled. She continued taking a generic statin, which my office renewed by phone on several occasions. However, she stopped taking her branded omega-3 medication for the elevated triglycerides because of the high copay and began using a dietary supplement omega-3 product. Unfortunately, her laboratory data showed that the triglycerides were as high as before she began taking treatment, and her LDL-C was now significantly elevated as well. Based on Anna's out-of-pocket cost for the omega-3 supplement, this exceeded the Tier 3 copay for a branded prescription medication. Furthermore, the omega-3 supplement elevated her LDL-C significantly. She said that when she lost her prescription benefits, she thought that she could substitute a dietary supplement for the control of high triglycerides. Anna is a bright and knowledgeable individual. She did her research and was able to tell me that omega-3 products were the treatment of choice and so safe as not to need any monitoring or prescriptions. Fortunately, we were able to work together and restart her medication again, achieving reasonable results. What makes this relevant to your deliberations is our mutual concern that patients with significantly elevated triglycerides be given treatment proven to be both safe and effective. Many physicians and certainly many consumers may be confused and think that supplements are regulated in the same manner as prescription and over-the-counter medication. Unfortunately, aggressive marketing may misrepresent the facts to vulnerable patients. In fact, the fish oil supplement that this patient was taking was both underdosed for potency and contained the DHA portion of the omega-3 supplement known to elevate LDL-C. The American Diabetes Association does not support recommending omega-3 supplements containing both EPA and DHA for people with diabetes for the prevention or treatment of cardiovascular events. Many healthcare professionals and patients are unaware of the distinction between a nutritional supplement and an over-the-counter medication. There are no over-the-counter omega-3 products that have gone through the 9-step approval process to evaluate safety and efficacy to achieve FDA approval. However, there are literally hundreds of omega-3 dietary supplements on the market in the U.S. that have not been reviewed for safety or efficacy by the FDA. Their advertising and communications are not regulated, nor are they required to report adverse events. They must simply state that they are not intended to treat disease. Most patients would not think that their elevated triglycerides qualifies as a disease, but rather as a simple medical condition. Treatment of significantly elevated triglycerides is one condition where many patients may choose self-medicating through their purchase of a non-prescription product. Access to care, prescription cost, and misleading marketing make this a fairly common example that we may address through expanding the use of prescription omega-3 medications with commonly used and widely available statins. I believe it is incumbent upon us to facilitate proven and effective treatments for these patients. Thank you.
Thank you. Will speaker number 6 step up to the podium and introduce yourself? Please state your name and any organization you are representing for the record.
Hi, my name is Karen Caruth, and I'm the Executive Director of Mended Hearts. I have no financial relationships. Mended Hearts is the nation's largest cardiovascular patient organization in the United States. Mended Hearts has 20,000 members nationwide, which conduct over 225,000 patient visits every year. Mended Hearts focuses on education, support, and empowering patients to take charge of their health. We do this by providing education, advocacy, and support for these patients, and we've been doing so for over 60 years. Heart disease remains the #1 killer of both men and women, resulting in more deaths each year than the top 5 cancers combined. Mended Hearts is a valuable and important patient community for this population. In the 60 years that we have been helping patients, the methods to treat cardiometabolic conditions have changed dramatically. As this panel is addressing, along with the FDA-regulated prescription drugs, there's a rise in supplements not regulated by the FDA. The problem's history is that omega-3s have long been recognized as a therapy of choice, but few recognize that the actual product recommended was not a supplement, but a prescription medication. But before the FDA approved the first prescription medication, hundreds of omega-3 supplements made their way to supermarket shelves and also in the hands of cardiovascular patients. There's a big difference, as the other speakers have mentioned, between a medication regulated by the FDA and those that are on the shelf, the omega-3 supplements. These products are often not 100% or 70% pure, and many contain DHA, a compound known to elevate LDL-C. This is particularly concerning because the majority of patients needing triglyceride modification also need to have their LDL-C lowered. Many patients do not understand the impact of these supplemental remedies on their health, and they either assume that the efficacy from supplements is the same as their prescription medications, or they do not share that they are on these supplements with their physician. Some patients use supplemental omega-3 products without knowing that they have high triglycerides. Clear guidance on when to take omega-3 medication and explicit guidance to take prescription omega-3 versus supplemental omega-3 will help clear that confusion. Patients with high triglycerides often need LDL-C reduction and may have other metabolic conditions. Therapies for these patients must be proven to be safe and effective, which cannot be ensured through an over-the-counter supplement. Clear guidance on the need for prescription omega-3 products may reduce patient use of supplemental omega-3s. This would facilitate better communication between the physician and patient. The physician would know that the patient is on omega-3 and would ensure that the patient is on a safe, regulated medicine with an understood impact on health. Thank you very much for your time and consideration.
Thank you. Will speaker number 7 step up to the podium and introduce yourself? Again, please state your name and any organization you are representing for the record.
Hello, my name is Dr. Gary Traeger. I'm a practicing endocrinologist. First slide, please. I'm an endocrinologist in private practice for approximately 28 years. We see many patients clinically and also conduct clinical trials. I'm the director of the Center of Diabetes Endocrinology in New York. I'm also an adjunct professor at the New York College of Osteopathic Medicine. I'm also president of the Lower New York chapter of ACE, which I'm not representing here today, but I'm representing myself and Amron, who has kindly paid for my travel, however, is not compensating me for my time. I had prepared a much different slide set, which I will still use partially of, but I wanted to echo what some of the previous speakers have said, is that every day of the week I treat people with these kinds of conditions, diabetic, non-diabetic, people with lipids, and I have my patients coming in telling me that they are taking an omega-3 fatty acid, they're taking a fish oil, they're taking this, they're taking that. And I ask them to bring it in because most of them don't have a clue what they're taking. And with all due respect, Dr. Roberts, the over-the-counter are not over-the-counter fish oils. They're food substances. You use the term over-the-counter. Over-the-counter means that the FDA has approved and regulated them. Food substances are not at all regulated, but branded medicines are. And there are only 2 branded medicines that are regulated at the current time. I do believe that we should expand the regulation, and the FDA, I believe, is it's incumbent upon the FDA to give us this guidance and this doctrine as to what we could and could not use, should and should not use Because right now our patients are taking things that they have no clue. We even have one of our local radio hosts that has said that he's on 1,000 milligrams of omega-3 fatty acids and doesn't even know what the brand is. And it's not a brand, it's a food substance. And he is telling everyone, please try this because it's great for me. It even prevented my diabetes. So what we need is we need knowledge that's coming from this body, from you, to guide us and to tell the practicing physicians as well as the patients whom we can then counsel, tell them that you may be taking 4, 6, 8 capsules of this over-the-counter, if you want to call it that, but it's really a food substance, which is really not necessarily going to help them. You also, not too long ago, gave a guidance in terms of the amount of sushi, sashimi, etc., that people should be eating because of the heavy metal content. However, the non-branded medicines, if you want to call them that, food substances, don't have a purification process that, for example, Vascepa does. So I'd like to just go through a little bit. This is an old slide. It comes out of Framingham. If you take a look, it says 35% of the CHD occurs in people with total cholesterol of less than 200. And this is a 26-year follow-up. On the left is CHD, and on the x-axis you can see rising total cholesterol. No CHD, this is the distribution. If we look at people with CHD, this is the distribution. But what's even more interesting to take a look at is that the number of people, 35% of CHD occurs in total cholesterol less than 200. There is something obviously going on that LDL itself is not addressing, and it's not addressed by statins. There is excessive risk or residual risk. Here's a study that's talking about non-HDL being superior to LDL-C in predicting cardiac risk. This is in non-diabetic individuals. And so if you take a look again, LDL-C on the x-axis, relative risk on the y-axis, and non-HDL-C in the 3 colors that you can see up over here, when actually we do look and see for a contrast and for a comparison, what we can see here is that for non-HDL, there's a dramatic and incremental rise of risk and events based upon non-HDL cholesterol for the same level of LDL. If we take a look at some of these studies, these are very well known to us. We're talking about residual cardiovascular risk in major statin trials. On the left, we have secondary, middle, we have high risk, and on the right, we have primary. These are all very well known to us. And you can see that here's the LDL-C reduction. If I can get the pointer to work. Here's the LDL-C reduction that we can see. But you can see over here, in terms of placebo versus statin, we were talking about placebo versus Vascepa not too long ago. There is a major gap here in therapy. Because even though these people are treated the maximum dose of these medications, such as 4S was 40 milligrams of simvastatin, lipid was 40 milligrams of pravastatin, HPS 40 milligrams of simvastatin as well. And when we take a look at this, there is an unmet need. Now, if we take a look at CV risk in patients treated with intensive statin therapy in these 3 trials, this is Privatimi 22. On the right is TNT. TNT was looking at 10 milligrams versus 80 milligrams of Lipitor, and you can see that there's a definite risk missing here. This looks at the difference between people with diabetes and non-diabetes. You can see that the diabetic patients on statin have the same risk as the non-diabetic patients on placebo. This is an unmet risk, especially in the diabetic population, which I'm sure you'll review in a few moments when we're done. And here, looking at cards, again, you have a 32% risk reduction, but a 68%
The time is concluded for that presentation. Thank you. Will speaker number 8 step up to the podium and introduce yourself? Please state your name and any organization you're representing for the record.
My name is Dr. Elliot Brinton, and let's see if we can go into, our slides. Dr. Elliot Brinton, I'm president of the American Board of Clinical Lipidology, but I'm here not representing them, but just myself as a clinician and concerned citizen. I've been involved in academic lipidology for several decades. I'm on the Reduce It Steering Committee. I am receiving travel reimbursement for Amarin, but this presentation is mine and not theirs. I think we need to consider more the data on Gellus. I'm going to try to focus on things that haven't been covered yet. And this last point actually has been made very nicely by the earlier speakers. My rationale for approving the expanded indication for Vascepa is basically the clinical trial evidence for Gellus, which is a pure EPA study, therefore very similar to and I think relevant to Vascepa. Does Vascepa actually equal Epidel? They're both greater than 98% pure EPA ethyl ester. There's no known chemical difference between the two. So I think that Gellus is very relevant to the question today. You've seen that slide. I want to just point out that the primary and secondary prevention data were very similar. The curves separate well before 1 year. 80% of the patients were primary prevention. To the question of MACE and hard versus soft, realize that they had 3 hard MACE endpoints: sudden cardiac death, fatal and non-fatal MI. The risk reduction was identical for the hard MACE as for the soft MACE. Therefore, in my opinion, even though probe design open label is potentially problematic, I think that it is much less problematic than it would have been if that had not been the case. So I think it's important to realize that hard MACE was definitely reduced in this study. Pre-specified subgroup, 1,000 patients with a high triglyceride, low HDL, relevant to the expanded indication. Notice the increased risk and unmet need, as has been stated by others. This you've seen, but I want to point out that this was a pre-specified sub-analysis of a positive trial, therefore much more solid than some of the other sub-analyses that we've been looking at. And just to look at the risk-benefit ratio, I think is very, very important here. There was a 2.5% drop in the MACE composite compared to a 0.5% increase in total hemorrhage, but there was no increase in cerebral hemorrhage. So the most dangerous hemorrhage was not increased at all. Number needed to treat, 38 for 5 years. Number needed to harm for hemorrhage, 200. Glucose was talked about. I had not included this in my original slide because it was not statistically significant, but there was a 0.1% increase. Number needed to harm for glucose increase, 786. So I think the risk-benefit ratio here is strongly in favor of pure EPA, aka Epidel, Vascepa. Putting this in the context, and again, this has been discussed, but to point out, this is the only study at mid-dose EPA, the only study with pure EPA. DHA at best dilutes the effect of EPA, probably harmful. There's animal evidence that it actually downregulates the LDL receptor. So I think that's very important. And then to the point of the treatment, my back of the envelope is a little different than your back of the envelope. I've got it down to 133. I'm not sure exactly what the number is. But that was considered controlled. They had the option to up-titrate if it was not controlled according to Japanese guidelines. And if you think about the fact that 80% of these patients were primary prevention, current U.S. guidelines, the goal is less than 130. So I think that the statin treatment was pretty reasonable. A very important point is that reduction in CVD was comparable with higher versus lower LDL. So if your LDL was high, you still have the same CVD event reduction. So granted, this is suboptimal in terms of statin treatment, but in those who we would have treated more aggressively, it still seems to work very nicely. The Japanese patients eat a lot of fish, but the benefit was seen with an EPA over 150, and there was a 100-point rise with the 1.8 gram EPA. So I think anybody that doesn't eat fish is still likely to do nicely on 1.8 grams of EPA. With regard to the lipid changes, I know that I'm a lipidologist, we're considering lipids, but realize that the benefit was seen despite very anemic lipid changes in this study. The reduction in CVD was proportional to the on-treatment EPA level. We know that there's a linear dose response between dose and levels, and therefore at 4 grams a day, which is what we're studying in the Reduce It study, I'm on that steering committee, I think we're going to see a greater benefit. Okay, we don't know that until we do it. The last and most important point here is that Reduce It does address what few limitations there are of Gellus, and I think as it stands, we've got excellent data with Gellus. So just to summarize, we've got a drug that has lipid efficacy, reducing all the major adverse lipid fractions, has a lot of other things that we haven't talked about, and then you've heard the last part here. So I just think it's very, very important to say that we've got a drug that reduces CVD as a statin adjunct in the target population, excellent safety. Most Vascepa use is already in that space because it's 15 times more common than TG over 500, so we're basically validating what's happening in practice, which I think is actually a good thing. And it's way better. It's going to help us divert use, as has been said, against these dietary supplements, which are problematic. Lovesa, which has no data to speak of, and what data we have is adverse. And then the other triglyceride medications, which I think are also...
Thank you. Will speaker number 9 step up to the podium and introduce yourself? Please state your name and any organization you are representing for the record.
Thank you, Mr. Chairman. I'm 6'4" on the inside, so... There we go. All right. Thank you, Mr. Chairman. My name is Glenn Hardesty. I'm a practicing emergency physician from Arlington, Texas. And the question a lot of you asking is, why is an emergency doctor here? They don't do anything with lipids. But primarily what I'm here to talk to you about is the end point of cardiovascular disease. I don't deal with the prevention. I deal with the end point. Heart disease and stroke are two of the biggest killers that we have in the United States today, or are the biggest killers in the United States today. And the importance of treating dyslipidemia and lipid disorders cannot be understated. Prevention of foreseeable disease just makes sense in our current healthcare crisis. If we can get ahead of the curve and treat patients before they end up in the emergency departments, we'll gain a lot as a country. Now, I know there's a lot of discussion going on down the road about the Affordable Care Act, or at least we hope so. But there's no doubt that the cost of healthcare is being shifted back to the patient. And thus, they're going to be looking for other ways to treat their disease process. I think, as the other speakers have noted, having patients self-treat can be very dangerous. I don't need to explain to this group the dangers associated with self-medication and the outcomes that occur from that. Patients have this sense of, if it's natural, if it's organic, that it's safe. Uranium is a naturally occurring thing, but yet you don't want patients to eat it. So, for an example, I had a patient that came into my emergency department that had atrial fibrillation with rapid ventricular response. It means the top of the heart and the bottom of the heart aren't talking, and it's beating real fast. Well, she took something that was called a cleansing agent, something to clean the toxins from her blood. Well, it turns out that that was activated charcoal. Activated charcoal is something we use in the emergency department to absorb a drug when people have ingested too much or have been poisoned in some form or fashion for most poisonings. Well, guess what happened? The activated charcoal bound up her amiodarone, and she went back into, and her atrial fibrillation was no longer controlled. She didn't intend that to occur, but there's nothing that keeps patients understanding the importance of and the interactions between their supplements and the drug. So the need to ensure patient safety cannot be understated, and helping patients do the right thing by keeping it in a regulated arena. So thank you for your time.
Thank you. I believe that speaker number 1 is now present. Will you please step up to the podium and introduce yourself? Please state your name and any organization you're representing for the record.
I could do it this way. Thanks very much. I'm vertically challenged and challenged from my recent plane trip here. But this is very important. My name is Dr. Ellen L. Marmer. I'm a pediatric and young adult cardiologist who is trained at Presbyterian Medical Center in New York City. Have been in private practice for 43 years. I also have been practicing in terms of lipids in children and families with training at Johns Hopkins, and I've been in that area for 21 years. I've been a vice president of the American Heart Association and still a very active member in that group. Amarin has paid for my transportation here today, but I'm on my own as far as any other expenses, no reimbursements of any kind. I'm here as a patient advocate and to hopefully implore you to work differently on omega-3 supplements. One of the things that's important is that my fellow physicians in many respects do not understand lipids. They don't understand the treatment and the diagnosis. In particular, we have found out from Framingham and other studies that triglycerides are a very high risk factor for women of all ages. This may not even be measured, if measured, even measured properly in lipid analysis by non-initiated people. I have here, and I'm willing to submit to you, a perfect example of what's out there on the market that one of my patients brought me about a week ago, where her primary care said, well, just take some omega-3s, and that'll be good for your heart. She bought this from a box store because it said natural and heart healthy. It has nothing on the back. It says it contains EPA, DHA. There's a tiny, tiny little disclaimer that says the FDA, does not recognize this or does not have any intention of overlook for this kind of supplement. medical physicians, consumers do not understand the difference between over-the-counters, which are regulated, and the supplements, which are not regulated. It's very important, I think, for many reasons for the FDA to get into supplement regulation. But I'm speaking about the omega-3s in specific. As you've already heard from the others, diabetes has a particular problem in terms of omega-3s. Heart disease is still the #1 killer. I'd like to be number 10, actually. But we are number 1, and we have to do something that intervenes in a very positive way. I'm glad to submit the bottle to the panel. I'm also glad to submit this is a magazine that has supplements in it. All my pages that are tagged for omega-3 supplements, which brings up the problem of how they are unregulated, unappreciated, and consumers are deluded. And unfortunately, with triglycerides, the media has chosen to put all their efforts into total cholesterol and HDL without indicating that triglycerides are another very important factor. And I feel that we as physicians need to educate ourselves, but the FDA needs to help us educate the public. I thank you very much for listening today. Do you wish these? I would be glad to turn them in to you.
You may leave them, yes. Thanks to all of the open public hearing speakers. We appreciate your comments and your input. The open public hearing portion of this meeting has now concluded, and we will no longer take comments from the audience. The committee will now turn its attention to address the task at hand, the careful consideration of the data before the committee, as well as the public comments. So we will now begin the panel discussion portion of the meeting. Although this portion is open to public observers, public attendees may not participate except at the specific request of the panel. So I will read our discussion question. Do you want to post that? Pardon? Yeah, that's fine. So we have a single discussion question that has been posed by the FDA for review and discussion and comment by the advisory committee today, and I will read this through. In ANCHOR, 12 weeks of treatment with Vascepa, 4 grams per day, led to an estimated median minus 21.5%, and you can see the range and the confidence intervals and the statistics, a change in fasting triglycerides compared with the mineral oil placebo among statin-treated patients with mixed dyslipidemia at high cardiovascular risk. Changes in other lipid lipoprotein parameters, selected secondary and exploratory endpoints, are summarized in the table below as projected on this slide. And again, I'm not going to review these in detail. I think you all can see this. You want me to then read the next part of this? So the discussion question, and we can repost that slide with data as you wish. The specific discussion question is, please discuss the efficacy results from the ANCHOR trial, including the clinical significance of the observed changes in lipid lipoprotein parameters and your level of confidence that these changes will translate into a meaningful reduction in cardiovascular risk among the target population. So we're now open for comment and discussion. Yes, Dr. Hyatt.
There were several questions from this morning that were pending potential sponsor reviews, such as providing the relative risk and confidence intervals around bleeds in the ANCHOR study. Could we maybe find out if that information is available before we discuss this question?
Yeah, thank you for reminding me of that.
Yes, Mr. Chairperson, I have that information for Dr. Hyatt. Dr. Hyatt's request was regarding the 95% confidence intervals on the bleeding events, and those are provided on this slide. The difference from placebo was 0.86. The confidence intervals are minus 2.03% to 3.25%.
So I calculated a point estimate risk ratio of about 1.5. This is the absolute difference. Can you give me the relative difference?
I'd like to ask Dr. Brent Blumenstein if he can comment on this.
See, you're sticking with the perspective that the absolute risk is low. I get that. But I want to know what the relative risk is and the upper boundary around the relative risk, which is going to be high because there aren't very many events. But the point estimate's around a 50% increase. What's the upper bound of that?
Well, this was computed using Fisher's exact test, from which an odds ratio was derived, and the odds ratio was then used to compute the confidence interval that you see up there. So I'm not sure that doing
What's the odds ratio?
I would have to look that up, but it was part of the computation.
Yeah.
I'll look it up.
I would like some clarity on that if we could.
Yes.
If I could just add my 2 cents, I think for safety, that absolute risk increase is a little more relevant than relative risk.
I disagree. I think both are important, but the perspective here is not to get sort of lost in what's up here. That we're looking at an event rate of 1.7%, right, on placebo and 2.6% on 4 grams per day. It's roughly a 50% increased risk.
I don't know how you say that.
What?
I mean, the confidence interval for that goes from essentially 0 to infinity, so
that's right.
I'm not sure where you get a point estimate out of that.
I just did a simple ratio of 2.6 divided by 1.7.
I think that's a misleading ratio.
Mr. Chairperson.
So can we have an odds ratio for that?
That's also misleading.
Yes, we have an odds ratio for that.
The odds ratio is 1.513, and the exact confidence interval for the odds ratio is 0.353 up to 7.384.
Okay. So consistent with many previous meetings of many advisory committees, the idea of understanding safety when you're looking at an endpoint that is, for example, in this case, a surrogate endpoint, and you therefore expose patients to a short interval, 12 weeks, to find out if the lipid parameters got better or not, and we know that. It's the same approach that you take in understanding a diabetes drug. Does that improve glycemic control? A little different in a weight loss drug because that takes a bit longer. But typically these are populations that are at risk. We agree with that. These people are at risk for cardiovascular events. And so by definition, there's a huge data deficiency here. There's sparse data around the actual risk of a bleeding event, which I'm saying is really uncertain. I'm not landing on any particular thing, but the upper bound of 7-fold increased risk is only a high upper bound because there's so few events. And so it is a numbers game. But the point of the question is, do we have any confidence that this drug increases bleeding risk or not? And I would posit you can't say no. You can say, I don't know. And it certainly is a numeric trend for an adverse effect here. I'm just trying to understand what the boundaries around that adverse effect are. And if they're really, really broad, then I just get more concerned. And if they're really, really tight, I at least have some confidence to say to a patient, if you take this drug, your triglycerides will drop significantly, and oh, by the way, your bleeding risk might go up by 50%. And I guess I can't have that conversation today because of the gross uncertainty around those numbers.
So, Dr. Hurl, you have another comment on this same point?
Yeah, I think the data are sparse. There's no doubt about it. But I don't get much out of a relative safety risk or odds ratio unless the event rate is very high. So it's just a fact of life that our uncertainty in relative measures of tiny rates is so great as to make them almost not useful. But there's still a sparsity of data.
Completely agree with that. So in other words, can you tell me definitively today that this drug does not cause bleeding? That's my only point.
But I don't base that answer on anything relative.
Okay, Dr. Wilson, did you have a comment?
Yeah, so I think to help Frank and Bill, what about a pooled experience for this product? in patients taking aspirin or anticoagulants? That's sort of what I want to know. I think that's what Dr. Hyatt was leading towards, and we haven't really asked that yet. So it says in the footnote for that slide that all bleeding events occurred in people taking antiplatelet therapy. But we don't know how many people are on antiplatelet therapy. And you've got a collective experience of this product. So can you tell us that or maybe develop that? We'd like to know that.
Yes, Dr. Wilson and Mr. Chairperson.
Yes, sponsor.
So I have a slide I'd like to pull up. Shows in Anchor that requested element in terms of the numbers of patients on platelet inhibitors by treatment group, and then the corresponding numbers of patients with bleeding events.
Any comment?
So it doesn't appear to be an interaction. I mean, it's sort of the kind of expected, maybe a little low use of antiplatelet therapy in a high-risk population. But again, the data to support aspirin for primary prevention aren't very good. So I don't see gross imbalances here, and it doesn't suggest that there is a greater proportion of patients taking 4 grams a day that are also taking a platelet inhibitor that might increase their risk of bleeding. And given the size of the study, I wouldn't have expected to be gross imbalance. So I don't see an interaction here. And the only point was an earlier point to Dr. Roberts and the FDA is that you seem to gloss over the safety of this drug, and I just wasn't sure why. And I don't know if there's a bleeding risk or not. I don't know if there's a risk of worsening diabetes really or not, or transitioning people from prediabetes to diabetes. I just don't know. And when you're trying to judge the balance of safety and efficacy, I would say that we don't really have much certainty around the safety of this drug. And it wasn't really presented. And I see imbalances that I'm obviously trying to point to simply to illustrate the point, not to say I know. It's just to say I don't know. And the uncertainty makes it difficult, I think, to judge the balance of efficacy and safety. And that's the only point I was trying to make.
Thank you. Did the FDA want to make, Eric Coleman?
Yeah, maybe there was a little confusion, but we have been looking at various omega-3 formulations for the past decade in our division. And we, after review of the original NDA for Vascepa, and then looking at this supplement, we did not see any obvious glaring safety issues that hadn't been touched upon before. And we saw what the company was going to present in terms of potential safety issues. And it's not unusual for us to say, if we agree with the company on one issue, that we're just going to acknowledge that we agree with them, which Dr. Roberts did, and let the company give their side of the story. So I don't think we glossed over it. We didn't see anything that was certainly that appeared to be a significant problem. And we, in general, agreed with the company's assessment of the safety profile from these 2 studies.
I just don't know why you say that when the exposure is so low. How many patient years of exposure is there? And would you say the same thing if this was a new non-steroidal to treat arthritis pain? Or
well, that gets into the fact that people have been studying these formulations for decades.
But
so
usually in uncontrolled environments.
Well, we've had a lot of the cardiovascular outcomes trials that we discussed thus far, lower dose, but there was quite a bit of sample size there.
Yeah, but there's no patient-level safety database that integrates across those trials that you have access to?
No, we're looking at the publications.
Okay, any more relevant discussion on this point? Yeah, and we'll go to Dr. Harrell, and also you'd ask another question that we were looking for follow-up data on, so perhaps you could clarify your question, or we'll let the sponsor
yes, Mr.
address it.
Chairperson, I do have you wanted a transformation of particular data, and I'd like to ask Dr. Brent Blumenstein to provide that to you.
So as I understood your question, you were concerned about the possibility that the use of percent change as the outcome variable might have distorted the comparisons. And so I'm sorry that I couldn't fully understand what you were requesting. I took a stab at it. And this is just the triglyceride change against the triglyceride change percent. And shows you a relatively linear relationship between those two outcomes.
I think that comes very close, and just what I was getting at would be the plot of the percent change versus the geometric mean of the pre and post. That's the slightly more direct way to show that the percent change is the right measure. You want that to be flat, and you want the variability to be flat. But this comes pretty close.
Thank you.
Thanks.
Thank you. Dr. Parks, did you have a comment?
Yes, I just want to revisit what Dr. Hyatt's point is and the discussion regarding the safety database. The FDA team here is stating that they did review the safety in this application and the prior application, original application for Vascepa, and they did not see something that is new safety information, nor is there disagreement. But the point that you're making, and we appreciate that, is that now the applicant is coming in for a new indication, a broadened patient population. Now, having heard what the FDA's conclusions are on whether or not there's new safety information, you can weigh this into your consideration during the voting question. If you think that the benefit risk assessment now is something different because it's a larger patient population and you want more, then that's something that you should discuss at that point in time.
Thank you. Diana Hilaire, I think you had some comments or questions.
It's related to Dr. Hyatt's question, rather. I would like to ask about the adverse events. I think before there were benefits based on like hypertension and so on. How about the adverse events? Are there, for instance, with those compared with hypertension, or those who have comorbidities, or those who have diabetes only? Is the data available for that? With regards to adverse events, not only the bleeding events, but also others.
So the treatment, the patient population within Anchor was 73%. 73% of the patients had diabetes, and the overall adverse event profile was similar on that particular aspect between those patients with diabetes and those who did not have diabetes. And that's the one aspect of your question that I can address right now. The overall trial population, the adverse event was similar, so we did not see any significant differences between those who were on hypertension medications and those who were not as well.
I have another point to make. I would like to ask about whether we could consider both triglyceride reduction as well as here it's a decrease of HDL, but could we also consider whether it could be raised in a sense? What I mean is that, is it only the triglyceride and also the non-HDL-C that we're only considering at this point, but also do we consider the HDL component as well as, this is not necessarily relevant, but also, for instance, HSCRP.
Are you addressing that question to the sponsor?
It's, I think, more of the committee, more so, but it could also be related to them as well.
So would anyone like to respond to that? Yeah, Dr. Coleman.
My suggestion would be to stick with what's in that table.
Okay.
And if you feel strongly about other parameters, then to make comment about that afterwards.
Thank you. So I You have another comment? No, okay. I thought you had your microphone on. So I jumped the gun a little on the discussion question, and so before I go back to that, are there any other issues, questions, concerns that people would like to express prior to moving to that question? Yes, Dr. Britton.
Yeah, I guess I'm a little confused since the drug is currently approved for the initial indication. Patients would be able to, even if there's no new indication given, patients in the category of this new indication would be able to be prescribed this drug off-label, correct? And so I guess I'm not really sure I understand the consequences of the new indication to the patients.
Well, I'll let the company respond to this, but our business is to review the data that we're provided with. So this is a decision that we need to make. So that's why we have you here to try to help us make the right decision. As to whether people are using this off-label, legally people can do that. I mean, physicians can prescribe a drug for any number of reasons. If the company wants to respond to that, feel free.
Yes, thank you, Dr. Coleman and Mr. Chairperson. I'd like to ask Dr. Harold Bays to address that.
Yes, thank you for that question. So the question is, being that my understanding of your question is that since the drug is already available, why can't physicians just use them off-label? And I think it gets to the whole question of what's the point of the label. I think one thing to understand is there's difference of indication. So in this case, there is a clinical indication for this drug in use in patients who have their LDL cholesterol is under control with statin therapy, but continue to have triglycerides between 200 and 500 milligrams per deciliter. We've heard questions as to whether the guidelines, the strength of the data behind the guidelines. But one of the reasons there's not so much strength is because there's never been, what we heard is there's never been a statin trial done in patients with triglycerides between 200 and 500 milligrams per deciliter, but it's worse than that. There's never been any trial done where patients were enrolled who had hypertriglyceridemia that any lipid-altering drug, was used and showed benefit. All right. So what are clinicians to do? How do they move forward with these patients? And the best data that we have is reflected within the guidelines. So that's how, and you've heard many of the people here, the folks here in the, I guess you call them audience, I'm not sure what the term is, but these folks over here, talk about guidelines and how it does direct their care. So if you have a patient, what are you going to do when the patient comes in that has the high risk because their triglycerides are 200 to 500 milligrams per deciliter? Well, many clinicians are going to follow the guidelines. And so that's their indicated use. But it may not be the indicated use according to label. And one of the things I tried to say in my presentation is I think clinicians are better off and I think patients are better off when the label reflects what clinicians actually do in clinical practice. And so to the extent that you have this Vascepa that is the first person or first company to ever actually do a trial in a hypertriglyceridemic patient population, I think that's also good for patients.
Thank you. Anyone else want to comment on that point? Okay, Dr. Hyatt, did you have? Oh, yes, Dr. Rasmus.
I just wanted to add a comment. The label is also where you get to disclose your data and is the tool the company can use to promote those data. So eventually, this is also what makes them conduct an outcome trial because they want those data reflected in the label, so eventually they can promote them. So without the wording in the label, you wouldn't be able to do that.
To the same point, Dr. Yeah.
It also has implications for what third-party payers will pay or help the patient pay for, which I think is an important point.
Yes, and if Dr. Smith, if I could have Dr. Howard Weintraub kind of echo that same point.
I would like to move us along, and I will have another member from the committee here make a comment. Dr. Hyatt.
Just had the very brief question of the number of primary events and reduce it 1,612. How many are you proposing will be hard MACE and how many will be not?
So as I mentioned before, as we contemplated the precise study design, we did have this discussion about should we go with strict MACE or some expanded MACE. If we look at a study like AIM High or some other outcome studies, it might, border 50%. But that's the kind of the balance we had to strike. I mean, we've all had a great discussion today about the studies that have created some murkiness around this, and we're committed to conducting this first ever trial, and it will, in order to make it a trial that completes in a timely fashion, we went with an expanded MACE.
I get that. It's about half was the answer, right? About 50-50. Okay, thanks.
Any more comments, questions from the group here before we move on? So, having been a while, I would like to reread the discussion question. I won't go through the whole thing. I think if we just put up the question. So this is our discussion question for today, and I'm reading this as a lead-in to comments specifically related to this issue or things that you think are strongly related. So please discuss the efficacy results from the ANCHOR trial, including the clinical significance of the observed changes in lipid lipoprotein parameters and your level of confidence that these changes will translate into a meaningful reduction in cardiovascular risk among the target population. Dr. Seeley.
So I have a few comments in this regard. So I'm concerned about the table and there being so many measurements listed. In terms of when we say the observed changes in lipid and lipoprotein parameters, the study seems like it was powered for the outcome of triglycerides, and the others are secondary and exploratory, and it's nice they go in the same direction, but I'm concerned about putting a lot of emphasis on secondary and exploratory outcomes, and I personally would focus on the triglyceride lowering. And in just focusing then on the triglyceride lowering, I think there is effective triglyceride lowering in this new group of subjects with the 4 grams a day. It's limited in terms of knowing the full magnitude because of the changes in the placebo group, which are of concern to me. And I've seen no data that tells us that this will translate into a meaningful reduction in CV risk among the target population. I don't think the JELIS study, we can say that the JELIS study is different and point out the differences, but then come back and say we expect to find the same benefit. As was pointed out, it was an open label study. The cutoffs for entry of the lipid levels were very different than what we're looking at for the indication. So I'm really glad an ongoing study is happening, and I will be incredibly thrilled if the results of the efficacy study with outcome shows that Vascepa added to a statin decreases cardiovascular risk. I think it's a really important study. I would be thrilled with those results, but I don't think we have that information today.
Other comments? Yes, Dr. Britton.
I'd agree with what Dr. Seeley said. I guess to me, the fact that there are a number of studies in which we see the triglyceride change, but we don't see, at least we don't see evidence of a treatment effect on cardiovascular endpoints, to me is the key.
Dr. Hyatt?
I'm just puzzling a little bit over switching to the efficacy side. Just the history of what got us here, so that I recognize if you go back to the approval of statin drugs, that this division has a history of approving drugs in this space because they change lipid parameters in a presumably favorable way. And it was later that the statin trials showed dramatic clinical benefit, and that was a great thing on your part to collectively make that decision to let those drugs on the market. Now we're in a different space of add-on therapy. We've had these discussions a few years ago around the fibrates. And as I sort of observed the data from this meeting, it appears that the sponsor, I think appropriately, has committed to a cardiovascular outcome trial, which is terrific, by the way. I think you guys are doing a public good, no doubt, because of the wide use of these medications off-label or as supplements, and which is earlier discussed in the open public hearing. So my question to begin this thinking is has the division made a decision that these, if you're going to go beyond a triglyceride of 500 milligrams per deciliter, if you're going to get into this more kind of range where there are more patients, they're at risk, is a cardiovascular outcome trial really part of the program here? I mean, the label simply says this drug lowers triglycerides in people at risk, which literally is true. But in fact, the behavior would suggest that they're going to have to initiate, and they're in the middle of, a large cardiovascular outcome trial, which would imply to me that any new lipid drug add-on to statin would really need the same approach, which would suggest that a guidance might be forthcoming or something to help us understand a little bit more what's expected. Or are you just doing this because ultimately they want to have a label that says this drug actually works in terms of clinical benefit? And I guess I'm asking you all, where do you stand in this regard? Because literally, this drug does a terrific job lowering triglycerides. It makes the other lipid fractions look good, pretty much. But there's uncertain clinical benefit, and they actually have a trial launch to answer that question. So where are you in terms of the state of developing any drug that's add-on to statin to alter HDL or triglycerides or other lipid fractions?
If we just stick with this particular compound, remember that our discussions with the company started back in 2008, and we'd had conversations with similar companies in 2006, where it was primarily a triglyceride-lowering drug. And for a long time, people were getting the indication of severe hypertriglyceridemia over 500 based on just triglyceride lowering alone.
Right.
And if you read the guidances, most people agree that the first priority is to try to prevent pancreatitis. We've talked about, could we actually have a development program where pancreatitis was the endpoint? And I think that would be probably tough to do.
Yep.
But when we started to get into companies wanting to target this lower range of TG, it was clearly with the goal of selling it to reduce the risk for cardiovascular disease. So back in 2007, 2008, we weren't in a position to say, there's no way you're going to get this approved without doing a cardiovascular outcomes trial and completing it and then coming back to see us. We knew these other trials were ongoing, Accord, Aim High, Thrive. While not the same compound, we knew that they would add some information. So we felt it was very reasonable to say, look, do a lipid endpoint study for 12 weeks so we get to see what the lipid profile looks like. But we want you to at least have the cardiovascular outcomes trial up and running with 50% enrollment so that we know that even if we approve it now, it'll get done fairly quickly. And if the folks feel that it shouldn't be approved at this point, the trial's up and running and we still will get that data fairly shortly. I also think that if Accord Lipid and Aim High and Thrive were positive, I think we would have a different discussion today.
So I appreciate that. I'm still just wrestling a little bit with the only reason I could think of to lower triglycerides or raise HDL or change LDL composition, ApoB levels, particle size. The only reason to want to do that is to prevent cardiovascular events. I can't think of any other reason to do that. And by the way, I agree with you. It's hard to imagine an event-driven pancreatitis trial for super high triglycerides. I kind of smile when you think about that because that's just by inference that it's actually going to be good. We don't know that really. So the only reason to treat these mid-range triglycerides is to prevent heart attack, stroke, and death. So let me ask you the question another way. Why not require every new lipid drug coming on to be reviewed to demonstrate that it has a biomarker benefit that looks good, i.e. changes levels appropriately, but that's just a surrogate endpoint towards the actually clinically meaningful event-driven trial that then, like if you were developing a new antithrombotic drug, whether it's an anticoagulant or an antiplatelet, you'd be in the same position. It sounds like you've gone there, but it's not clear to me.
Well, you know, when we're dealing with compounds that, if you could call them more pure LDL lowering compounds, that's where we feel the most comfortable in terms of using that as a surrogate. I think the further we get away from LDL and start getting into TG or LP(a) or even non-HDL, and we have in place, if your compound is primarily raising HDL cholesterol, you do have to complete an outcomes trial before you can submit your application. So we do have that requirement for HDL raising drugs based on the recent experience with CETP inhibitors. But again, this was the first case with triglyceride.
Okay.
So this is a test case. And we weren't in a position back in 2008 to feel like we had the proper support and data to say to Amarin, there's no way you will ever get this indication unless you complete an outcomes trial. We thought there was enough uncertainty to give them the advice we did. And as it turns out, we've had additional studies that have been completed that I think do play into today's discussion.
Thanks.
Yeah, we're going to have a comment back from Dr. Seeley. Next. Dr. Seeley first, then come here.
So I'm still kind of stuck on I think there's a contrast between the discussion and the vote that's hard for me. So we don't know whether this is going to translate into a meaningful reduction until this current study is completed. But we could have confidence that in the patient population of people with CHD and CHD risk equivalent, it will effectively lower triglycerides. So I think that's why the question of do we also need to know that it will reduce CVD risk is part of the indication, because I think we've seen effective data that in the population that the company wants the drug approved in, it will lower triglycerides. I just don't know if it's going to lower CVD risk. So I could approve it for lowering triglycerides if that's the way the question was phrased. So I'm very confused about how the voting question is phrased in contrast to the discussion question.
Do we want to get into the voting question before we finish with the discussion?
I would recommend we defer that, and but if I forget, remind me that we ought to have a little discussion before the vote about this question and perhaps others that come up.
To help inform the discussion point, though, Dr. Parks, others can correct me if I'm wrong, but what defines sort of our effectiveness requirement for a drug is not laid out by statute. It is actually covered by case law, and really comes down to what's a clinically meaningful endpoint. Okay, so what that means to each person around this table might be different, and that's why we want to hear your discussion. Because some would argue that, for example, if you saw a 40% reduction in LDL, I'm confident that that's a clinically meaningful endpoint, a clinically meaningful result. But what we're asking you to do is to look at the lipid changes in front of you that were demonstrated in this trial and say, how confident are you that that's a clinically meaningful result? We know that there's an outcomes trial that's ongoing. We're not going to be able to say anything definitive about cardiovascular risk until it's completed. So the question is how confident are we that this is clinically meaningful now?
And that's what I answered, and I think maybe...
Yeah, Dr. Everett.
I think to
sort of echo Dr. Seeley's comments. I think that in my view, the epidemiology for on-statin triglycerides being an important risk marker for future cardiovascular events is mixed. It's not unequivocal or totally clear. There are certainly some positive studies which we've heard about. There are some others which suggest other things like BMI or ApoB or better markers of that risk. Secondarily, it's not necessarily clear that reducing, to me, triglycerides is going to impact that risk. In particular, I think, we all talk about statins and use LDL as the canonical marker, that if it goes down, cardiovascular risk will go down. Quite frankly, outside of statins, that assertion has not really been demonstrated to be true. The ongoing IMPROVE-IT study of ezetimibe may give us some insight, but it's enrolled, well over 25,000 patients. It's not like it was stopped early for efficacy, and we don't know. We just don't know. And unfortunately, for the average cardiologist, the field of adjunctive agents is littered with failures. We've heard about a bunch of them this morning, such as niacin, and ezetimibe, at least in my view, up until this point, is another example. And then, so the fibrates are another. And so, to echo Dr. Seeley's comments that, how important is triglycerides, I think is an interesting topic that is, you could take either sides of that issue. The actual risk reduction associated with lowering triglycerides, frankly, for lowering any of these biomarkers apart with a statin, is not clear to be of substantial benefit to me.
Dr. Rasmussen.
So I think today is a particularly difficult discussion to have. I think we can all agree that despite standard of care with statins, there's still a significant residual risk that has been difficult to address. So I'm not sure that statins, when they were introduced, that's the bar to set for future innovations within lipid lowering. It may be that differences from now on will be incremental. And I think that's where, it's going to be a bit of a stretch. We don't have the outcomes data to substantiate that triglyceride lowering will be the next biomarker to manipulate. But it's a good candidate. I think we can all agree on that, and I think we all commend the company for having initiated the Reduce-IT trial and have gotten this far. And I'll just say that on behalf of all of industry, setting a bar that's higher and drawing a line in the sand right now, saying future agents will likely have to demonstrate cardiovascular risk lowering through hard outcomes, will significantly impair innovation. These types of trials cost several $100 millions, and I'm not sure companies the size of Amarin would endeavor into this kind of activity if that was the future.
Thank you. And Dr. Wilson.
So I think we have, there's one slide I keep looking back at, and it was Michael Miller's slide number 21, if you have a handout. And stare at it several times because it really summarizes an awful lot of what we've been saying, what Brendan just talked about. Even in these other trials that have statin on board, and those LDLs are typically what we're seeing in modern clinics, basically starting on 100 and lower. You can use non-HDL if you want. They lowered triglyceride. They lowered triglyceride to the same degree that is seen with Vascepa. So it's pretty hard to say, that this is going to necessarily translate into a clinical difference. I share Dr. Seeley's optimism. Let's see the results with an outcomes trial. That's really where the proof in the pudding is from my perspective at this point.
If we could have a response, I see someone from the sponsor would like to make a statement. Again, just very relevant to this point in a way that might help us to address some of these questions.
I'll touch a little bit on each of these comments. So first, Dr. Hyatt, this program was actually designed up front to be comprised of 3 studies, Marine, Anchor, and Reduce It. It did represent actually a new kind of standard in terms of working up front collaboratively. Those special protocol assessment agreements were vital as a small company to get the clarity so that we could marshal forth the human and other resources to put this program into play. And Marine and Anchor were conducted in parallel, as has been described. The Marine original submission had both the Anchor and Marine safety data reviewed and included. And Reduce It was actually started shortly thereafter. And I think to Dr. Britton's comment, I want to just accentuate that when we look at those numbers that Dr. Wilson had up there, those were TG lowering in patient populations that may not actually have been at risk by virtue of their TG levels. So we have to at least keep that in mind when we look at the table 1 in the FDA questions relative to those failed outcome trials. And what we, by virtue actually of a lot of collaboration with the FDA, is we were aware of some of the limitations of Accord, AIM High, and HPS2 Thrive. They've been built in to Reduce It. And I think we need a balance between patient care access and the science. And Amarin is stepping up to the plate and filling what we're all saying is a very murky situation that needs to be met head on. And that's the challenge for us as a small company, putting in play what is a huge clinical operations effort. 11 countries, 450 plus sites, as was mentioned, triple-digit millions of dollars to get the answer. And we think that when we look at elements of Accord, elements of AIM High, elements of HPS2 Thrive, elements of GELIS, along with our Anchor lipid and lipoprotein benefits, and our safe and tolerable profile, we think when you look at it, there's manageable risk, and we don't gloss over, Dr. Hyatt, the risk. We take post-marketing surveillance very seriously. We have a great opportunity to look at all these adverse events of interest and Reduce It, whether it's bleeding, glucose metabolism, worsening new onset diabetes. That's part of our commitment to the ongoing patient safety. And so I just want to leave you with that message that we have, this safe and tolerable drug with these signs across these various domains of what we consider to be plausible benefit. Yes, some of the lessons are hypothesis generating, agreed, but you really do need companies like Amarin to step up to the plate and tackle these important scientific issues, and I'll just leave it to that.
Thank you. I would also just like to make a comment, or a couple comments, and I'm really following up on something 2 points that Dr. Seeley made, but I'd like to emphasize more and hear back whether there's disagreement with the emphasis I place. And a key point is that I still feel very uncomfortable about the proper control group. And I have heard all the arguments and I've thought about them here and before coming here, but I remain uncomfortable with comparisons against placebo. And the study looks well designed, but the data are what the data are. And sometimes things happen in studies that we don't anticipate or that aren't controlled when we thought they might be. It's very important because as we look beyond the triglyceride changes to the changes in the other lipid parameters, they're substantially affected by our choice of whether the best control is the baseline or the best control is the placebo group. And for example, if we just look at non-HDLC, the difference against placebo is a decrease of 13.6%. The decrease against baseline is 5%. Now, my experience in the world of how data flow would be, if I had to make a bet, I'd say the truth is probably somewhere in the middle. But the point is that I feel in trying to address this question of the observed changes in these lipid and lipoprotein parameters, I feel uncomfortable with what a number of those changes are. And what this relates to also is the question that we've discussed a little bit, which is if a decision is made to approve ultimately the drug, what the actual indication ought to be. And so the cluster of listed lipid and lipoprotein changes, to me, don't have all equal motivating power supporting stating that as an indication for use of the drug. And I'm sort of going all through this because I'm looking at how people actually, some people might actually make decisions on use of the drugs, and the label is clearly very important for that. So we can have our extensive discussions here about triglycerides or some other endpoints and what we think about their magnitude of change. But that same consideration may not occur once individual elements are put in a label. So again, I'm just re-emphasizing my concern about whether the data derived against the placebo control we have are overstating the degree of change in some of these lipid endpoints. And I'm concerned that ultimately, as this goes through the process of approval, if it does, that be taken into consideration when labeling occurs. Dr. Hyatt, you look like you had a comment on this same point.
Sure, the placebo responses were interesting, and I appreciate the FDA and the sponsors' attempt to explain it, which they couldn't. It's a small study. I mean, it's possible that it's a fluke, and it may not play out in the REDUCE-IT trial. I think that trial will perhaps inform whether that's a biologically active placebo or an inert placebo. Even if you subtract that out, the changes from baseline are pretty dramatic on triglyceride as a primary. So I don't think the drug is inert. It's biologically active. It's changing the primary endpoint significantly. You could ask the DMC of REDUCE-IT to monitor the placebo changes, perhaps, and ask if they see signals of concern. Not sure what you do about it, but it may not reappear. The only other comment I'd like to make is back to the sponsor's earlier assertion, indeed. And I also think you've chosen the right phenotype. I think that a lot of discussion has occurred over whether these other trials that were negative because patients didn't start off with the baseline elevation in triglycerides. And when we reviewed fibrates, was it 2009? When was that meeting? It appeared that if you subgrouped all the four trials that were being looked at and take this subgroup with the high triglycerides, low HDL, that you actually did have some clinically important information that might suggest in a properly designed trial, which I think you've done in terms of picking the baseline characteristics, should answer that question. And really, I think, back to your point, Robert, if you're struggling a little bit over the anchor results, I can understand that, but I don't know how much is that going to affect an event-driven trial, whether the placebo is biologically active or not.
Dr. Britton.
Yeah, I just, again, want to make the point that it looks like the 4-gram results are a lot better than the 2-gram results. And I was hoping we would get an actual test of that. But that, to me, provides a lot of comfort that we have this concern about the placebo group. The 4 to the 2 is a conservative, obviously a conservative treatment effect of what the 4 to a true placebo would be. I don't know if we have a list, a table that's like this comparing 4 to 2, but having that 2 in there, I think, helps.
If I can just follow on that,
yes.
Though, if there's a placebo issue, though, Dr. Pertain, 2 gram per day patients were also taking placebo pills to get a total pill count the same in all groups. So your 2 gram per day group would also potentially be confounded by placebo.
Okay,
if there's an issue.
I did not know that. Okay.
Dr. Wilson.
Yeah, I wanted to share some of my thoughts about the other lipids. Dr. Seeley keeps bringing this up. And, so the big trials that have had further lipid lowering, let's say you have your patient with an LDL cholesterol less than 100, is so you had TNT atorva 10 versus atorva 80. And then the other big trial was the SEARCH trial out of the Oxford group, which essentially had Simva 20 versus Simva 80. And they got only about 12% difference, which is sort of what you would expect. These were mega trials, large numbers, and bigger or as big as the trial that this sponsor is putting together. And they were positive on TNT and they were null on SEARCH. So the trial was not positive. So you got to be careful even looking at LDL lowering. And it was even predicted, when you look very carefully, that SEARCH was probably just not quite big enough, not quite long enough. The signal was in the right direction, but not positive. And I'm concerned, even what I'm leading to is with the lipid changes here for the ApoB types of molecules, the LDL, the non-HDL, the ApoB, it's not going to translate into a positive trial, the trial that's ongoing. So I'm predicting that the trial is going to be null. It's just not going to. So I just don't think they're getting meaningful differences in atherogenic lipids. So that seriously affects my thought as I'm trying to make a decision going back and forth. I'd like somebody to convince me otherwise, because right now it looks like the atherogenic lipids are just not changing enough in the favorable directions.
Dr. Smith, could I be recognized to have someone address Dr. Wilson?
I would like to keep the discussion here for now. Yeah, Dr. Hyatt.
So let me pose just another question. I think Reduce It is the right patient phenotype based on everything we know. And addresses the weaknesses of the failed trials that have been recently reported. Typically, an interim analysis done, to classically end a study, as we all know. But the FDA has taken a staged approach for diabetes drugs, and now this is ruling out safety rather than ruling in benefit. I don't know if the analysis plan is even considered this, but if we all conclude today that we really don't know if it's beneficial to lower triglycerides substantially or not, what would you do if the point estimate were going in the right direction in the event trial, confidence interval still hadn't made it statistically significant as to formally stop the study, but it had a staged approach? From my perspective, that actually might be reassuring to let a drug on the market, or expand the label, at an earlier time point than one normally would do. Until you had the study completed, was in-house, and you looked at the data and said, yeah, it's safe and effective. Would you all consider that approach? Because you're asking us to say, do we want to support this today based purely on its lipid benefits and uncertain clinical benefit? If you ask us this question in 3 years, when you absolutely know the answer, then that's a different story. We're somewhere in between.
Dr. Parks will have probably more to say than I do. I have limited experience in this, but we have been willing to do that with the obesity drugs, as you know, and the diabetes drugs. But that is because people take diabetes drugs and obesity drugs for reasons other than lowering the risk for cardiovascular disease. The only reason someone would be taking Vascepa in this scenario is to reduce the risk for cardiovascular disease. So I don't think that paradigm doesn't quite fit, I think, in this scenario, where you really don't want to deal with any uncertainty when the endpoint is the only endpoint that matters. So,
Dr. Seeley?
One comment I just wanted to make back to Dr. Wilson is similar to what we talked about statins appearing to be unique in their benefit in cardiovascular disease prevention, primary both and secondary, and it appearing to be that there's probably more than just happening to the LDL cholesterol. I would keep my mind open, although I agree there's no evidence, but my mind open that Vascepa may have other effects concomitant with the triglyceride lowering that may be beneficial for CVD prevention.
Thank you. So if there are no further comments, I will endeavor to summarize what this group has said, and after that I will ask you to amend and correct my summary as you think should occur. So I think what the view expressed is the consensus view of this advisory group is that the anchor data show effective triglyceride lowering. There's been concern expressed about the placebo group against which this was measured regarding the potential for overstatement of the triglyceride lowering effects. That's a concern, but not a conclusion that it's an inappropriate placebo group. The available data do not strongly support the cardiovascular outcome benefit of Vascepa. In other words, cardiovascular disease clinical outcome benefit is uncertain based on the data that have been presented. There has been substantial discussion about the importance of clinical outcomes as the rationale for use of Vascepa in patients with mixed triglyceridemia. In other words, those cardiovascular outcomes are, in essence, the full rationale for use of this drug. There was substantial discussion of whether outcome trials should be required before new approvals for lipid-lowering drugs without resolving this question in the course of that discussion today. And finally, I meant to mention this earlier, concern has been expressed by the committee about the multiple lipid and lipoprotein parameters that have been listed in this discussion question, especially when the study was fundamentally powered for triglyceride lowering. So there remains some concern about how much emphasis to place on those other lipoprotein endpoints. Would anyone like to amend or correct my comments? Yeah, Dr. Harrell.
Not necessarily correct, but just another way of thinking about the multiple lipid parameters is I don't like to penalize a sponsor for trying to learn more. And so I don't see the number of parameters here as quite as much concerning as some do.
Well, and again, speaking for me personally, I wasn't responding to the issue of number of parameters. What I was responding to is an issue of the magnitude of effect is not the same for all of them. And therefore, the degree to which I might answer this question about whether or not the lipid-lowering effects are convincing are actually specific, perhaps, to each of those parameters. Dr. Hyatt, a comment on this?
It's a great summary. And perhaps the other thing we also discussed is that the label's intent to identify a high-risk group of patients for whom this moderate level of elevated triglycerides, that particular patient phenotype, is in fact a well-supported phenotype to study. That I think some members felt that even though it wasn't proven, that it was very appropriate to test the hypothesis that lowering triglycerides in that patient population would make a lot of sense, and that the sponsor should be commended for actually taking that challenge on, and that they're doing the right thing to study this particular population.
Yeah, I had actually meant to state that as well, and just to expand on that a little bit are the comments again from the advisory committee that the recorded study in fact appears to be a well-designed study in a very appropriate patient group, an important study, and one that should substantially help to answer the question before us about whether or not cardiovascular outcomes will be improved with Vascepa. Any other comments on my summary? Okay, so then I think we'll move to the voting question. But before we do that, I'm recalling that we're going to have some discussion about some specifics that may help people to resolve how to approach the voting question. So we'll come back to that. And Dr. Seeley, you had a question on the floor regarding that, and Dr. Coleman, you were starting to respond. So do you need to restate your question to get us back in the game here?
Well, in terms of the voting question, I want to understand, are we voting as to whether we have efficacy and safety data for Vascepa to lower triglycerides in patients with hyperlipidemia? The end. Is that the question we're voting on?
So let me, I'm sorry to interrupt here. Let me read the voting question to put that before us, and then we'll come back to this discussion. So the voting question that we're going to get to and the vote in a second here is, and this is our single voting question today, is taking into account the described efficacy and safety data for Vascepa, do you believe that its effects on the described lipid lipoprotein parameters are sufficient to grant approval for co-administration with statin therapy for the treatment of patients with mixed dyslipidemia and CHD or CHD risk equivalent prior to the completion of REDUCE-IT? And then again, you, of course, after the vote, will be asked to provide the rationale underlying your recommendation. So that's the question we're leading into. Oh, sorry for the interruption, Dr. Coleman.
So are we voting on whether the sponsor has shown us sufficient information that Vascepa will effectively lower triglycerides? Because that could be one interpretation of the voting question in this population. Or are we voting that that the medication is indicated for CVD prevention?
I think you need to take into account the efficacy and the safety data, and then decide if you believe that the changes that have been observed in the anchor trial, for example, lead you to believe that when this is co-administered with a statin, it will reduce the risk for cardiovascular disease. Now, if you're confident that that would be the case, you would vote to approve it now. If you're not confident, then you would say...
Okay, but it's not how the vote question is written.
Is it clear how people should... Okay. Do we need to change the wording?
I'm open to that if you are. And maybe we'll have a little more discussion while you think about that if you want, and then we'll come back to that. Dr. Britton was next. I was going to go to Dr. Britton here.
I have a question.
Okay.
So a mixed dyslipidemia, does that mean the 200 to 500 for TG? I would think that's what it is, but it's not defined in that statement. Is that right?
Dr. Smith.
Well, to that specifically, mixed dyslipidemia is the term that the sponsor has proposed in their indication. Now, we're aware that there are several ways to define mixed dyslipidemia. And if that were how it would be worded in an indication, I think a physician would be allowed to interpret that as they wished. In general, Dr. Coleman, correct me if I'm wrong, I don't think that we have laid out, for example, specific triglyceride or HDL cutoffs that would define syndromes like this in labeling. It might be mentioned in the clinical studies section, what an inclusion criteria was or things like that, but that's best I can help you out with. If you have a comment after your vote about what you think mixed dyslipidemia is, or if you would have other alternative recommendations, feel free to chime them in.
I would recommend before it becomes finalized, if this does get passed, is FDA define it. So whatever it might be, because right now it's undefined, and I don't know what that definition is personally. As somebody been in lipids for quite a while, that's a unique term. So,
Dr. Parks.
So I just want to visit the question about whether or not the wording of this voting question should be changed. We do not want to change the wording, And part of the reason why is that there's been a lot of thought has been put into this prior to this meeting. And we recognize that there are a lot of imperfect data when you come to this meeting. The indication that is written up here is the indication that has been proposed by the company. And so if there is any sort of uncertainty about that, if that's going to weigh into your vote, then state that. You have that opportunity to state that when you explain your vote.
Yeah, Dr. Wilson.
So that's not a barrier at all to how I'll make my decision. But I think when used in practice, there will be concern exactly what that means. So that's number one. Number two is, it says CHD or CHD risk equivalent. The guidelines that are going to come out, they're being released, AHA, ACC guidelines this week for internal review by those bodies. Hopefully will be out by November. It's already public that we're moving to CVD risk. I'm not sure we're saying CVD risk equivalent. So that's something else for the FDA to bear in mind as they're deliberating as this moves forward. So it's a little bit of synchronization. But CHD risk and CHD risk equivalents are probably not going to be the common parlance 2014 and onwards. So.
Sorry, Dr. Rasmussen.
Sorry. I just have a question for Dr. Coleman or Mary Parks. Is it fair to assume that if an indication were granted, that it would be very clearly stated that there are no cardiovascular outcomes data? So it would be clear that even though the intent is ultimately to reduce cardiovascular risk, that those data are not available at this time?
If you look at the, for example, if you look at the latest statin, pitavastatin, that we approved, there are no outcomes data for pitavastatin, so it lists that limitation that there are no data on CHD morbidity and mortality. You know, we thought when we drafted these that your response to the first point, discussion point, would likely lead you fairly straightforwardly to your vote. And you know, basically, we're asking you what we are faced with, which is we have these data right now. We have the data that we've discussed today, and we need to make a decision. Do we approve Vascepa for this indication now, based on the data we have today? Or do we say we need to actually see the REDUCE-IT trial completed before we feel comfortable granting this indication? So that's what we're asking you.
Dr. Smith, could I be recognized and have Dr. Howard Weintraub weigh in on that question of why approved now? Because just to be clear, from Amarin's side, we're not interested in potential overstatement of efficacy, you know. And
yeah, I'm will. We'll have a brief comment on that.
I'm Howard Weintraub from NYU. I have interaction with a lot of primary care physicians through my teaching and clinical obligations, and I think the things that are obvious to me is they are focused on guidelines and they are focused upon the fact that they want to lower things that are high. That's blood pressure, blood sugar, LDL, and other lipid parameters, and they view the triglyceride guidelines, whether or not they're supported by enough data that would identify you're going to reduce events, as something that they should do. I think they are conflicted with the issues of talking about safety, the data about fibrates and statin interactions, because this is the group. It's very, very real. They've experienced them themselves, and every EMR sets off alarms when you want to use a statin with a fibrate. And then, of course, the data with niacin is self-explanatory. So I think that the data here shows a benefit in lowering triglycerides, and that there are other associated lipoproteins that show the right direction. And I think that this is something that for the time, and I think it's important that we realize that all the other data that we've been knocking around goes against triglycerides at about anywhere from 25 to 50, 40% below the proposed treatment level. And I think this is something that physicians will utilize. I think if you went to 100 primary care physicians and cardiologists and endos and said, this is the drug that we have, will you use it? And they would say, in the maximum, they would say yes. If you ask me, I would use it at this point because I don't perceive a risk, and I certainly perceive it to be safer and just about as effective as the other drugs that we would currently combine with a statin. And regrettably, none of the other studies answered the question we wanted, which is if you optimize statin, do you need the other stuff? So I think until that information comes out, this would be a useful adjunct to the therapy. Thank you.
Yeah, thank you. Dr. Harrell, I think you were next.
Yeah, I would just appreciate a very brief statement from the division about their current thinking about conditional approval.
Can you explain what you mean by conditional approval?
Approval subject to an ongoing clinical trial showing something.
So I think what you're referring to are the situations in which the agency can require a clinical trial to be conducted as a condition of the approval. There are 4 scenarios in which the agency can require such trials: accelerated approval or under Subpart H, which this application is not subject to. That was never a matter of discussion, my understanding. Is that correct, during development? The other areas are deferred pediatric studies, so that's obviously not going to relate to this one. The animal rule, and the 4th one would be under FDA, which is for safety reasons. So if there is a safety concern related to the product, or new safety information if the product has already been approved on the market, then the agency can require a study with specific timelines that are to be met by the company to answer the question of both efficacy and safety. Well, safety for the FDA. For efficacy, that would be under accelerated approval, but again, that was not something that was discussed with this application.
So I'm not hearing anything that applies related to surrogate endpoint needing validation in a clinical outcome study.
Not with this application.
Dr. Hyatt.
So I can see the challenge you're facing because you've sort of set yourself up for it in some ways, because historically you've approved lipid drugs because they improve lipid parameters, and diabetes drugs because they drop blood sugar and A1C. And it's only later that we really learn whether those decisions were the right thing or the wrong thing. So it would seem to me unfair to the sponsor if you've historically approved lipid drugs because in a population they do something that looks good. Why would you suddenly change the bar at this moment in time? Which is kind of why I was asking that earlier question about, well, what's up? I mean, are you going to change the way new add-on therapy should be judged? But on the other hand, if you do approve it and the reduce the trial's negative, what will you do then? Will you withdraw the drug from the market?
Well, that's a big hypothetical, so I'll tread carefully. But if we were truly convinced that the trial was negative, showed no benefit, I suspect the first thing we would do is we'd contact the company and say, look, we think that this trial clearly failed, and we think you should remove the indication from the labeling. Now, if they say, okay, we agree with you, fine, everything's fine. If they disagree, then we go down a whole different path that involves lawyers and that involves potentially misbranding, imminent hazard, and suspect it could be very prolonged before anything would happen.
So, I mean, a simple approach to all that is to say, well, you already said that the reason that we would give a drug like this in this population is only one reason: it's to reduce cardiovascular risk. If there's uncertainty about that, it's simple enough to say, wait till the trial's over, don't do anything, don't paint yourself in a corner or evoke more problems because you approved something and then you had to sort of change the label later. Just wait for the event trial to conclude, just judge whether the primary endpoint is positive or negative, and then it's a simple decision at that moment in time. But historically, you haven't done that, and this sponsor's done everything you've asked them to do, and they've started the trial, they're in the middle of it, and they've got a drug that does what it's supposed to do. Why would you?
Well, let me remind people what I said this morning. The special protocol assessment is a binding agreement. Unless it's determined that a substantial scientific issue essential to determining the safety or efficacy of the drug has been identified after the testing has begun. Now, we believe that Accord Lipid, AIM High, HPS2 Thrive, and perhaps some of the omega-3 fatty acid outcomes trials that have been published in the last 2 or 3 years, that does change the landscape.
Remind us what was agreed upon, because usually social protocol assessments are around the trial design.
Right. So in other words, this would, well, I don't want to get too far into this, but let's just say that they are binding agreements about the design, the analysis, the size of the trials. But if some external information comes up after the testing began that you think influences the size or the analyses, then the agreement doesn't necessarily hold.
But I know you stated this at the beginning, but just so I understand it, what did you actually agree to? I mean, the anchor trial was under a special protocol assessment, and Reduce It was under a special protocol assessment. But the fact that we're here 50% way through enrolling Reduce It, I think, was that part of your agreement? That is.
Right.
So you hit that number, and that's part of the SPA agreement.
Right.
So that's where we're here.
What we said was you would have to have a 12-week study, anchor.
Done.
And have the outcomes trial 50% enrolled before we would accept a submission for consideration of approval. So we agreed to the design, to the size, to the analyses of those 2 studies. But as I've mentioned, if there are new data that appear that could influence the design or the size of the analyses, that can be factored in.
That certainly, and that's clear. So, but absent that new data, do the agreements that you've made essentially commit you to say you have a positive anchor trial, you've had 50% enrolled in a cardiovascular outcome trial, and we agreed that if you did the lipid things that you said you'd do in anchor and the outcomes trial was 50% recruited, that we would grant you a change in your label. Was that the agreement?
Yeah, I mean, for example, if Accord Lipid and AIM High and Thrive were all positive, I think we'd have a very different discussion going on.
Yeah, and the only thing that could change that agreement is an interpretation of new evidence that came after the agreement.
Or obviously the data that are generated in the studies themselves. I mean, if you don't think the TG lowering that they showed is sufficient, that's obviously
but it's statistically significant.
I know. I'm just saying, if someone argued that wasn't as large as they'd like to see.
Okay, Dr. Park.
Yeah, I think that we're getting into the slippery slope, Dr. Hyatt, of the hypotheticals. What if FDA got this, what would you do? What this panel is being tasked with is to vote on a question based on the data that the agency has before it. So you've heard this morning from Dr. Coleman and Dr. Roberts the regulatory history, when this IND came in, when they were discussing the development program, and what was the evolution of the science from 2008 until today. And so based on those data, that's what the voting question should be really focused on, not on the what ifs Accord or AIM High did this or that.
Dr. Cook, you had a comment or question here.
So this is a little more of hypotheticals as well, but I just want to make it clear to myself at least, if this is approved and the sponsor then finds that they can't complete their Reduce It trial because they have dropout, they have an inability to continue to recruit, there's no mechanism for going back other than that same rather cumbersome mechanism of what if the trial's negative. That's correct. We have no way of forcing them to complete the trial.
That is correct.
Dr. Everett.
I think my points have been covered in the previous few minutes discussion. I'm mostly addressing this gulf between discussion point 1 and the approval question 2 that Dr. Seeley had identified earlier.
All right. Any more discussion from this group prior to the vote? Yeah, I would prefer at this point not to have that further input. Does that seem appropriate to those of you who've been here longer than me?
That our view of Reduce It is that clearly, if Reduce It was negative, we would expect a re-review of the application. I just wanted to make that clear.
Yeah, I appreciate that, but I somehow feel like comments from the FDA with their regulatory powers and the limits of those powers is sort of more truly relevant than what a sponsor might state. And this is not meant in any way that would not imply that what you would actually do.
I just want to make sure that no one has any more questions about the voting question. I want to make sure everybody has a clear sense of what we're after. Because you only get to vote once.
So I will reread the voting question, okay, and then we'll answer that question Dr. Coleman asked. So taking into account the described efficacy and safety data for Vascepa, do you believe that its effects on the described lipid lipoprotein parameters are sufficient to grant approval for co-administration with statin therapy for the treatment of patients with mixed dyslipidemia and CHD or CHD risk equivalent prior to the completion of Reduce It? So regarding Dr. Coleman's question, any more questions, expressions of uncertainty, need for clarity? In which case I think we'll progress to the vote. So for the voting question, we'll be using an electronic voting system for this meeting. Once we begin the vote, the buttons will start flashing on your microphone there, and will continue to flash even after you've entered your vote. Please press the button firmly that corresponds to your vote. If you are unsure of your vote or you wish to change your vote, you may press the corresponding button until the vote is closed. After everyone has completed their vote, the vote will be locked in. The vote will then be displayed on the screen. The DFO will read the vote from the screen into the record. Next, we will go around the room and each individual who voted will state their name and their vote into the record. At that point, you can also state the reason why you voted as you did. We will continue in the same manner until all questions have been answered or discussed. So if there's no further discussion, we'll now begin the voting process. Press the button on your microphone that corresponds to your vote. You will have approximately 20 seconds to vote. Please press the button firmly. After you've made your selection, the light may continue to flash. If you're unsure of your vote or you wish to change your vote, please press the corresponding button again. So you may vote now.
The vote was yes 2, no 9, 0 abstain.
So we'll now go around the room, starting on my right with Dr. Everett. And again, if you would state your name and your vote and make any comments that you would like to make about the reason for your vote.
My name is Brendan Everett. I voted no. I'm optimistic about the data presented today by Amarin. I think that it could very well offer the potential of substantial benefits for patients with coronary heart disease or coronary heart disease risk equivalents. I am wary, however, of approving a drug that has potential market of tens of millions of people without any hard efficacy data. While I understand that's a very high bar to set for industry, I think in this case, and given the fact that the scientific landscape has shifted rather dramatically over the past 4 or 5 years, I think it's, in my view, the right standard for when we should use novel medications with unknown risks in patients. Thank you.
My name is Frank Harrell, and I was willing to take a leap of faith about the safety profile and to narrow the scope to the lipid profile, and because I was 0.6 and there was no maybe.
I'm Pam. Excuse me. I'm Pam McAllister. I just remain unconvinced that there's any clinical benefit based on the very small sample size and the fact that the placebo was not inert.
William Hyatt, I voted no. I think the evidence to date is not convincing that lowering triglycerides is clinically beneficial. I think there are compelling reasons to do a cardiovascular outcome trial, and I certainly hope it's positive and commend the sponsor for doing so. But I read the question as implying clinical benefit and answered beyond the purely easy way to answer that question was, does it actually lower triglycerides? And I'm convinced it does. But whether that translates or not remains to be seen.
Before we go on, if we could go back to Pamela McAllister, if you could restate your name and state what your vote was for the record.
I'm sorry. My name is Pamela McAllister. I voted no.
I'm Diana Halliar. I voted no because with regards to the fasting triglycerides, for instance, I laud actually that it was reduced. However, I see that with the HDL cholesterol, it doesn't necessarily, it's rather glossed over in a sense. And also the small sample size, I think there needs to be more time with regards to seeing the effects on cardiovascular outcomes. And I think there needs to be more diversity as well with the sample population that is undergoing this trial.
I'm Ed Gregg. I voted no. I thought the efficacy from both Anchor and Marine were actually quite acceptable, as well as the risk profile. But given the implications in terms of the potentially large segment of the population that would be eligible for this, I think that we need to look beyond that short period of 12 weeks and triglycerides as an outcome. And when you do that, it requires us to look at this broader segment of studies, which is not particularly satisfying, but doesn't really help us make that decision. Given that there's an ongoing trial underway, it makes sense to wait for those outcomes.
I'm Ellen Seeley. I voted no. I voted no based on that I think the medication has effective triglyceride lowering benefit, but that the new data that was presented today shows that it's not clear that triglyceride lowering necessarily translates to a CV benefit. And I took the vote to mean that there would be an implied CV benefit. And that was my reason for voting no. But I also wanted to just state for the record that I really think we need small companies to be developing medications. And the concern that we are setting a high bar, which is important for our patients, but that the bar that we're setting may be too high for a number of small companies to meet. And particularly to revisit what happened with this company, where they really did everything that anyone would have asked them to do. And we usually like to reward that. And I think that the trial that they have designed to look at outcomes is a really important one, and that we need to, as a society, look at ways to support that these trials get done when companies are depending on interim approvals to be able to support the cost of studies. And we know that's what's happening. That we need to find other ways to support companies, whether it's through federal money or other monies, to allow important trials to get completed.
My name is Robert Smith. I voted yes, and my vote was based on my considered balance of efficacy and safety, recognizing that the data for neither of these is as adequate as I might wish it would be, which is usually the case in trying to make decisions like this. I was influenced strongly in my vote by what I consider to be favorable safety data. I fully accept that those data are not perhaps as extensive as one would like to have to be convinced that there are not safety issues. But compared to the safety profiles of most other drugs that I'm familiar with, it's a very highly safe intervention from the data that we have. In terms of efficacy, I perceive there being quite substantial triglyceride lowering, irrespective of what the choice is for placebo group. And my main issues with the placebo group have had to do with other lipid endpoints. And I accept and understand the data that are available from prior studies, but I feel that the dose differences in this study and the higher risk patient population or potential higher benefit patient population based on triglyceride levels, at least as is being addressed in the recorded study, versus prior omega-3 studies, for example, whereas I remain very uncertain about how outcomes will come out from the recorded study, I feel uncertain rather than certain that this will not be effective. So putting all this together, I feel that approval of the drug now would expose patients to potential benefit that we have yet to learn more about at a very low risk of harm. And what we're looking at is a period of the next 3 to 4 years until the recorded study is completed, perhaps a little more than that by the time it's analyzed and assembled. I chose not to make a vote based on concerns about how the FDA would deal with the issue if it turned out the recorded study did not show outcome benefits in cardiovascular disease. But I voted on the situation as I've described it.
I'm David Cook, and I voted no. I have a high degree of confidence that this medication will lower triglyceride levels. I think I'm less certain about its beneficial effects on the other lipid parameters, although I think it is possible that it does have a benefit, a favorable effect profile on those levels with longer study. But I did vote no because of the concern over using a surrogate endpoint for what really is the health benefit, which is a decrease in cardiovascular risk, which I don't think has been proven for this medication and has been pointed out, hasn't yet been proven for other medications aimed at improving lipid profiles other than statins. And I feel at this point it's important to look at those hard endpoints and see data to support those hard endpoints before extending approval.
I'm Erica Britton. I voted no. I agree that I'm confident about the triglyceride lowering, but it's unclear implication to the clinical benefit of that lowering. I did feel that some of the data presented were quite promising. Some of the clinical trial data were quite promising, so I'm optimistic that the outcome trial will be positive. I certainly hope so. I guess I was influenced partly by the fact that the product is already on the market, and that does give treating physicians some flexibility.
Yeah, Peter Wilson, I voted no. I won't repeat all the other comments that were said very ably by the other panelists, but I think of safety, I think of lipid changes, I think of subclinical disease. And more, as I look at how we're developing care and guidelines moving forward, is we need guidelines that are based on trials. And I'm not sure we really need any more agents being prescribed because we think they're going to work. We should really rely on what we know that works and get fairly simple messages out to clinicians. I did have one concern, one that's not been mentioned up to now. I had a concern that there would be overprescribing potentially. There already is overuse of some of the omega-3s without proven benefit. And there may be might have been an approval, and there still might be, depending how the FDA interprets our voting, for patients not on statins, who would then be prescribed an omega-3 in this mixed dyslipidemia group. But the point was we were voting especially on those on statins, and with a promise, I would like to say that's an important promise, that there will be a trial and it will be concluded, and a panel like this will get to review the results. So I think we've moved beyond trusting lipid results. The major 3 trials that have focused on similar types of populations have shown that we have to have the trials in hand to guide our decisions.
So I would like to thank you. That concludes the voting part of this meeting. I would like to thank the sponsor for thoughtful and very clear and very helpful presentations. I would like to thank the FDA for the same in their analysis and for their other interpretive and informative comments for us. All those who spoke in the open public hearing portion of this meeting, I'd like to thank you as well for your input and your comments, and all the other members of this advisory committee, voting and non-voting. Would the FDA like to make any final comment?
I'd just like to again thank all the panelists for the time you put in before today's meeting, and as well as the time you put in today, and we appreciate your feedback. And again, we really thank you for what you do.
Okay, so this meeting is adjourned.